Good morning and welcome, everybody. On behalf of the Black Midwifery Collective and Health and Medicine Policy Research Group, we are so excited that you are here joining us for the first event in our four-part Illinois community-based birth justice strategic plan launch series. My name is Anna Yankelev, and I'll be your host. I'm the Director of Strategic Workforce Initiatives at Health and Medicine, and I've been working closely with the Black Midwifery Collective to facilitate the strategic planning process and develop the plan itself. Over the past year and a half, dozens of community-based birth justice workers have supported the development of a new strategic plan that works to ensure that every birthing person in Illinois has access to the community resources, settings, and support that they need for a safe and positive perinatal and birth experience. Simultaneously, several researchers conducted surveys, focus groups, and key informant interviews with community-based birth workers to better understand their barriers, needs, and priorities. These findings together helped inform the key themes that shaped the evidence-based foundation for our strategic plan. In this four-part webinar series, we will review the findings from these different research projects and culminate in an overview and release of the strategic plan during the last session. You are welcome to join for any or all of the webinars based on your interests and availability, and we will make recordings of all the sessions available after the series concludes. Today's session features two research projects directed by the Health and Medicine Policy Research Group. I'm delighted to be joined by Dr. Camillie Williamson and Karie Stewart, lead researchers on their respective projects. They will be discussing relevant workforce data for doulas, certified professional midwives, and birth centers, the barriers they face, and the opportunities to better support their sustainability and thrivability. After we go through some housekeeping, we will review some key terms and provide a brief introduction to birth justice and why this work is so critical. Then, Camille and Karie will each go through their research to share their findings and recommendations. We hope to have about 15 to 20 minutes at the end of this session for a lively Q&A. Some housekeeping notes. Please introduce yourselves in the chat if you haven't yet done so. We'd love to know who you are and who's joining us today. As I said, we will be recording and sharing the recordings of all of the sessions, and we will also be translating them into Spanish. And we hope to have 15 to 20 minutes for Q&A at the end. So be sure to post your questions in the Q&A box or function within Zoom and not in the chat. A quick review of some key terms so that we're all working from the same definitions. Perinatal refers to the time period from when someone becomes pregnant to up to a year after giving birth. Community-based refers to the culturally congruent care that unjustly served communities receive outside of health and hospital systems. And birth justice is part of the broader reproductive justice movement and includes the right to choose whether or not to carry a pregnancy, to choose when, where, how, and with whom to birth, including access to traditional and indigenous healers, and the right to breastfeeding support. And we are grateful to Jamara Amani, Executive Director of the Southern Birth Justice Network, for this definition. And just a quick note on gendered language. While we try to use gender-neutral language to describe birthing people wherever possible, we do use gendered terms like women or maternal when we are referencing research that utilizes those terms. So, why do we need this plan? Illinois has a big problem. Not every birthing person in Illinois has access to the same opportunities for a safe and healthy birth experience, leading to often preventable serious injuries and death that impact some communities more than others. Avoidable and unfair differences in health outcomes like these are known as health inequities. So we believe that we need to achieve birth justice in order to eliminate these health inequities. So which communities are more likely to experience the harmful effects of perinatal health inequities? Black women are more than twice as likely as white women in Illinois to die from a pregnancy-related cause. And when we look just at the city of Chicago, that number jumps up to 6.5 times more likely to die from a pregnancy-related cause when compared to white women. Black women are also more than twice as likely to have potentially life-threatening conditions or complications that occur during labor and delivery when compared to white women. And women on Medicaid are over 3 times more likely to die from a pregnancy-related cause than those with private insurance. And this is especially important because 40% of all births in Illinois are covered by Medicaid. Older women, women who are over 40, and women with less than a high school education are also more likely to die from a pregnancy-related cause than younger women and women with more than a high school education. And it's important to note that while recent years have shown improvements to mortality rates for birthing people overall, the rates for Black birthing people in particular have remained unchanged and in some cases have even worsened over time. Notably, 1 in 3 deaths occurred during pregnancy and 1 in 3 occur more than 60 days postpartum, meaning that the majority of maternal deaths are not occurring during labor and delivery. And importantly, and horrifically, 9 in 10 pregnancy-related deaths are classified as at least somewhat preventable. And this statistic right here is ultimately what we are trying to change. And our strategic plan explores what we can do to help eliminate these preventable deaths and promote the health and vitality of all birthing people. So what causes these inequities? For many people, especially those from communities of color, immigrant communities, and rural communities, accessing comprehensive perinatal care within health and hospital systems can be difficult or even dangerous because not everybody can access the care they need, either because they live in a perinatal care desert, like residents of 1 in 3 Illinois counties do, or because they can't afford the care they need. And there simply aren't enough workers to meet the demand, either within our health systems or within our community-based workforce. And our first 2 sessions are going to dive much more deeply into this problem. Racism and discrimination prevent many people from seeking or receiving quality care, and many women report experiences of dismissal, discrimination, or disrespect due to their race, insurance or immigration status, age, or substance use. Our third session will dive more deeply into this issue. Many birthing people have pre-existing or new medical, mental health, or substance use issues, and these are issues that need dedicated care beyond the walls of the delivery room. And finally, those struggling with access to healthcare, safe housing, healthy food, reliable transportation, livable wages, childcare, and other factors known as the social determinants of health also experience worse maternal health outcomes. It's important to note that many birthing people must navigate multiple of these barriers to get the care that they need, and often these barriers impact and intersect with one another. This can make the conventional perinatal care system inaccessible and in some cases harmful for many birthing people, particularly for communities most impacted by maternal health inequity. So we believe that community-based birth resources and supports can help address these barriers and advance birth justice. Our strategic plan, to be released at the end of the month, provides lots of evidence as to how community-based birth resources and supports, either on their own or in combination with health and hospital systems, are proven strategies to improve health outcomes for birthing people, reduce barriers to care, and reduce healthcare costs. So I'm not going to go into all of that now. You can join us in session 4 for a deep dive into that content. But we do know that we have a long way to go before we can ensure that everybody has access to the community-based resources and supports that they need and deserve. And that's the focus of our session today. Our session today, the current and future landscape of doulas, CPMs, and community birth options in Illinois, will discuss where we are now and where we need to go to advance birth justice. I'm going to introduce both of our speakers now, and we will start with Camille's research and then move over to Karie's. We will address all questions from the Q&A at the end of the session, so please be specific in your question if it's for a particular researcher. Dr. Camille Williamson is the lead researcher for the Illinois Certified Professional Midwife and Doula Workforce Landscape Analysis Report. She is a seasoned social worker, researcher, and social justice activist with over 20 years' experience. Over the span of her career, she has built and sustained community-based programs for youth and young adults, stewarding emerging behavioral health practitioners to develop socially responsible practice and providing trauma-informed therapy to women and children who've experienced domestic violence. Her most recent work centers on improving maternal-child health and evaluating the work experiences of community-based birth workers. Karie Stewart is the lead researcher for a study on expanding and strengthening community birth options in Illinois. She has recently been appointed as the Director of Family Health Services at Choice's Carbondale Center for Reproductive Health and maintains part-time clinical practice as a certified nurse midwife at the University of Illinois Mile Square Health Center located on Chicago's South Side. With 9 years of experience as a midwife, she is a fellow of the American College of Nurse Midwives and currently holds the position of vice chair on the board of the National Black Midwives Alliance. Ms. Stewart earned her Master's of Science in Nursing, Master's of Degree in Public Health, and is in the first year of her doctoral studies in nursing. As an experienced maternal health researcher, she is currently a co-principal investigator on a $7 million funded Karie grant titled Melanated Group Midwifery Care, and has successfully completed a $2 million funded HRSA grant titled Community Maternal Health Care, both focusing on the Black birthing community in Chicago. In 2019, she established Melanated Midwives, a nonprofit organization that offers financial support to BIPOC student midwives during their training with the aim of diversifying the midwifery workforce. Thank you both for joining us this morning, and Camille, take it away.
Thank you so much, Anna, and thank you so much for inviting myself and Karie to speak with everyone today. Excited to share all of this data with everyone. Okay, well, let's just jump right in. So as Anna mentioned, I'm Dr. Can everyone see my screen?
Yep, you're good to go.
Okay, great. As Anna mentioned, I'm Dr. Williamson, and I'm excited to share a wealth of information that I learned by surveying and talking with doulas and CPMs pretty much throughout the year of 2025. So just to start, the purpose of this research project was to complete this environmental scan of doulas and CPMs that are working throughout the state to get an understanding of what this workforce looks like. This includes an assessment of their needs to expand and increase the birth worker provision of care throughout the state. In addition, this project also documents the types of clients that CPMs and doulas see, the scope of services that they provide, their compensation, their experiences and opinions on Medicaid enrollment and reimbursement, as well as their experience of integration in formal healthcare settings. So why does this matter? So I really appreciate the introduction that Anna gave us, specifically around maternal mortality being a major public health crisis in Illinois, but also throughout the United States. In the most recent 2025 Illinois maternal mortality data report, it is noted that 72% of pregnancy-related deaths had some chance of being prevented, and 19% had a good chance of being prevented. So this crisis that we find ourselves in, I feel, is solvable. And all birth workers are essential to determining and driving and implementing the solutions that create better maternal child health outcomes for birthing people, and that includes CPMs and doulas. So just briefly, I just want to share the methodology for this particular study. So it was both quantitative and qualitative. The survey, we wanted to understand workforce demographics and locations, the demographics that they serve, the services that they provide, what their professional development is like, their compensation and income levels, their experience with Medicaid, and their experience with formal healthcare and hospital settings. The focus groups and key informant interviews, which is the qualitative portion of the study, was really meant to have a deeper dive into what we were gathering from the survey data. We wanted to specify or learn more about specific workforce issues related to education, training, and capacity levels. Also, accessibility of professional development, additional perspectives on compensation and Medicaid, the types of barriers and opportunities to integrating into healthcare settings, gaps that CPMs and doulas see in client resources, and personal needs for support and prevention of burnout. So just a quick overview, the survey was launched in April 22nd of 2025. We did have 149 respondents. There were 25 incomplete or blank responses. So we ended up having a total of 124 complete surveys. And of those participants, 105 were doulas, 19 were CPMs, and the survey closed in July. Focus groups and key informant interviews were completed throughout July and August of last year, and 11 doulas participated in focus groups and 5 CPMs participated in key informant interviews. So let's jump into the doula survey data a bit. And throughout this report, the survey data will also be complemented by some specific quotes and some qualitative analysis from the focus groups and key informant interviews. But to begin, the top 3 counties where doula respondents provide services, I'm sure you could guess, are, Cook County, DuPage, and Will County. So Cook County being the largest service area for doulas, and DuPage and Will coming in second and third. But I thought it would be helpful to share a heat map to show where most of the doula care is concentrated. And you can see that for our state, most of it is concentrated in Chicago and the surrounding counties. Not a whole lot throughout the state. Also, acknowledging what Anna mentioned in the beginning about the need for expanding the birth worker workforce. With regard to doula demographics, of the respondents that completed the survey, most of them identify as white, Black, or Latina. Most of the respondents do not identify as LGBTQAI plus, but however, a quarter of them do. And regarding concordance, racial concordance, do doulas provide services to clients of their same race? We kind of ended up with a third. So about 29% say that most of the time they provide services to clients of their race. About half the time, 32% say about half the time that they do, and 30% say that sometimes they do. Also, we asked, do doulas provide services to LGBTQAI plus populations? And 35% say yes, they do. 25% say yes, rarely. So not a whole lot of engagement with people who may identify as a part of that population. We also asked specific questions about vulnerable or marginalized populations that doulas serve. And 65% say that they work with teens or young people. 57% say they work with domestic violence survivors. And 57% say they work with people who are unhoused or people with insecure housing. Also, some other larger numbers, people struggling with addiction, alcohol, marijuana, opioids, people with disabilities, immigrants, and people with limited English proficiency. And I think this is a very important slide as it pertains to things that I think we'll be talking about a lot more in terms of the strategic plan, and that there is a need to have a connection to resources for doulas and CPMs to be able to provide the most comprehensive care in an integrated way to vulnerable and marginalized populations. As we understand, across the spectrum of perinatal care, if people have insecure housing, struggling with addiction, struggling with domestic violence, that complicates things in terms of being able to have safe birthing options, being able to have safe recovery from birthing. One thing that I also thought was wonderful to showcase is the types of services provided by doulas. So if you look at this chart, it's not surprising to understand why doulas have such a positive impact with birthing people. So 96% provide birth support, and birth support could be a number of things, but one of the things that is most notably discussed is advocacy for the birthing person, especially when they're the most vulnerable during labor and delivery, and being able to advocate for what that patient needs, what their client needs, and being able to have a preliminary discussion about how they would like their birthing plan to go, and an understanding of what kinds of things that could come up so that that birthing person has a person in their corner to be able to remember the plan, talk about if pivots need to be made, and to support that birthing person throughout the process. Also, 88% providing postpartum care, which we know is critical for people who have just given birth, being able to have an understanding of safety for infants, rest, nutrition are all things that doulas talked about in focus groups in terms of delivery of postpartum care. 83% providing prenatal care, which may include a number of different things. This research also revealed that a lot of doulas have specialized training in other areas. There were some respondents that talked about their experience being massage therapists as well, being able to create a relaxing environment and stress relief for the clients that they serve as doulas. And just touch on one more, 71% providing lactation support. So a lot of birthing people may have some challenges with latching and pumping and storing milk and weaning, and having someone by your side to be able to walk you through what that looks like and be able to demonstrate and work with you to breastfeed, I think is also critical. So let's talk a little bit about capacity levels of doulas. So about 71% serve about 1 to 5 clients a month, and then it drops considerably to 21% of those who are serving 5 to 10. And you can probably imagine why, just looking at that previous slide. There's a lot of comprehensive support that's being given to birthing people, and you certainly want to be able to do your best with all of the clients that you serve. But other slides will reveal why there might be some other capacity issues. So we also asked, do doulas ever have to turn any clients away? And 48%, about half, say that sometimes they do. And about 45% say that they never do. So I want to say a little something about this. One of the things that I really, really appreciated in all of the focus groups with doulas is how committed and passionate they are to providing comprehensive care to the clients that they serve, how important this work is for them. And for them, it's more hard work, work that is necessary to build communities and to support people, not only when they're most vulnerable, but as people are growing their communities. Let's also get into a discussion of income, and you'll see later on in certain slides why I'm bringing this up. So on average, the income for doulas providing this work is about $34,302 per year. Now, that's not a lot of money, especially if you are living in Cook County area, especially if you're living in Chicago. This is a very expensive place to live. And I also want to say, and you could probably guess from some of the previous slides, that not only is this work very intense in terms of the types of services that are provided, it's labor intensive. As you can imagine, a lot of doulas are going to be on call while they're supporting the clients that are on their current caseload. And doulas are not paid for being on call. And so to that end, many doulas find that they have to work supplemental jobs for more income. About 63% of the doulas that we surveyed say that they absolutely work other jobs to supplement their income. And in terms of how doulas are compensated, about a quarter of them are paid directly out of pocket by their clients, but about half of them are paid by community programs, which makes sense because a lot of the doulas that we surveyed are a part of groups, community-based practice groups for doula care. Let's talk a little bit more about some of the barriers and challenges for doulas. So one thing that was discussed quite a bit in the focus groups are the barriers that they experience in getting additional trainings and certifications. So about 84% of doulas surveyed say that the costs are too high. and that the trainings are expensive and some of them aren't offered a lot. And pretty much most of the doulas that I spoke with said that this is a continuous problem. Not only in terms of the cost being too high, but they're not necessarily accessible according to the type of labor that doulas are doing. So, for example, many doulas are on call. They also have their own. They also have their own lives to conduct, their own children to take care of. So they're not always able to present to an in-person training. And so they require a variety of delivery of training opportunities to keep their professional development up. Let's also talk about the Medicaid reimbursement rate for doulas. So about 70% say that it is not a sufficient rate. Upon getting into the weeds of this in focus groups, I thought these were some very important quotes here. If the average rent is $1,300 for a 2-bedroom, I should get paid that for at least one client. And you also have to consider the cost of childcare for the doulas themselves. And I don't know if there's anybody here with us today that is paying for childcare, but that's like another rent or another mortgage that you have to pay on a monthly basis. Another quote that I thought was important to share today is that some folks felt that $2,000 for each birth would be closer to a livable wage. And so just to break this down a little bit further, assuming that a doula provides all specified services and at least 8 one-hour visits of perinatal education or other services, for example, they would only be reimbursed about $1,300. And this amount does not account for the on-call time and the travel time and expenses and the amount that is the same per birth, regardless of if the labor was 40 minutes or 40 hours. So there's a flat rate for a birth, according to the Medicaid reimbursement, that does not take into account how much time that may have taken for a doula to be able to shell out. According to our survey, 3 out of 4 doulas work with 20 or fewer clients annually, yielding an average income revenue from Medicaid reimbursement of about $27,000, which is far below what is considered a living wage in Illinois. And just to note a few barriers and challenges, a third noted that they don't really have the knowledge or training to navigate the process. And this is something that I think also came up quite a bit, not only in focus groups, but at the Birth Justice Summit itself. It's a cumbersome process and people feel that they need more support, not only with the process of signing up for Medicaid, but billing as well. And in terms of integrating into former healthcare and hospital settings, about 60% of doulas note that they do have challenges with this. But these quotes also indicate some specific areas that I think are bright spots to consider. So many people noted that initially they weren't very welcome, but with persistence, building rapport, and indicating that they're there to be able to have a positive impact for the birthing person, has been helpful in terms of being able to become more welcomed, and perhaps building more relationships in the future will be an integral part of whatever this integration process will look like. Switching very quickly to CPM survey data, the top 5 counties in which our respondents work are, of course, Cook County, Lake County, Kane County, DeKalb. As you can see from this heat map, you can see similar to doulas, they are very much concentrated around Chicago and the surrounding counties. So also indicating we still need to do more work to expand this birth worker workforce so that it reaches more places where there are needs and so that we have an equitable response. Very quickly, the biggest demographic of CPMs that took this survey was white, and most of them do not identify as LGBTQAI+, so about 84% do not. Most of the time, the CPMs that took this survey indicate that they do serve clients of their race, indicating a high racial concordance, and about half say that they work with clients that are LGBTQAI+, and about 37% say yes, but rarely. Again, noting some marginalized or vulnerable populations that CPM service, you'll see it's very similar to doulas in that 76% work with teens or young people, 94% work with domestic violence survivors, and 53% work with immigrants. Again, in terms of types of services provided, you'll see that 100% of them provide postpartum care, 95% provide lactation support, and 95% provide birth support, and about 90% provide prenatal care. Very similarly, again, to doulas, CPM service about 1 to 5 clients per month. And you see that there's, again, that quick drop to 26% in terms of those that serve more than 5. And very similarly, again, to doulas, do you ever have to turn clients away? About half say that sometimes they do, and a little over a third say that they never have to. And looking at the annual income for CPMs, you'll see that the average salary, or the average income rather, is about $53K. However, very similarly to doulas, about 63% of CPMs also have to work other jobs for supplemental income. And typically, CPMs are compensated by private insurance or paid directly out of pocket by the clients themselves. Some particular barriers and challenges for CPMs. Again, in terms of professional development, 69% of CPMs say that the costs are too high. And also, I thought this quote was very important. Hospitals have a lot of resources, but we don't have a seamless connection to center home birth training. So this is an opportunity that I think is possible, especially in terms of how do we look at all of the ways in which to provide comprehensive birthing care for all Illinois residents. And although CPMs currently do not have a reimbursement rate, we still wanted to know what they thought. And about 90% say that what is being discussed in terms of Medicaid reimbursement rates is not sufficient. Again, noting that there's a lot of burnout in the field and they take on many clients to be able to pay bills and maintain a car and equipment, that's not necessarily taken into account with Medicaid reimbursement. Also, a lot of what was discussed in the key informant interviews in terms of mentoring upcoming CPMs, many of them recommend that they have supplemental income from other jobs. This last quote, which I thought was really important to take a look at, we need to be compensated at least $10,000 per birth. It includes perinatal to postpartum services. So looking at the full spectrum of care that is provided for a birthing person is critical to understanding what a livable wage or what a fair wage would be for the labor that is being given. Some additional concerns that CPMs had about the Medicaid process, 47%, about half, saying that it does not pay enough to be financially feasible. 37% noting that it might be too much work to manage billing. And again, similar to doulas, not having a lot of knowledge or training to navigate the process. In terms of challenges with integrating services, here's where a lot of CPMs had a lot to share, in particular around harm and disrespect to patients. I've seen a lot of providers do some harm during routine care. The hospital feels like human rights roulette. And this is particular around making sure that there's clear respect and dignity for the patient that's being cared for by the hospital staff, and making sure to have informed consent for all procedures and examinations. And I think that a lot of CPMs noted that they really value what hospitals are able to bring, but really think that it should be that whatever kinds of supports, exams, technology that is beneficial to patients, it has to be, the patient still has to have their human rights centered. And there should be less fear mongering during the birthing experience and more willingness to integrate care and all options that are best. And so finally, I just want to get into a few recommendations. Overall, the data suggests that there are some priority action steps to be taken to ensure that doulas and CPMs, which represent a community-based birth workforce, is expanded to meet the needs of birthing people racially, culturally, and in specific regions throughout the state where there are some maternal care deserts. Also, this workforce needs to be well supported with a livable, fair wage and some social support for burnout, childcare, and accessible, affordable professional development on an ongoing basis. And lastly, doulas and CPMs need better integration into healthcare and hospital settings with access to social support networks to provide more care and resources to vulnerable populations. And just as a closing slide, here are some specific areas of how to look at some strategic supports to strengthen this workforce. So number one, taking another look at that Medicaid rate so that it incorporates all types of services, especially the types of services that might be more hidden, like being on call. So both doulas and CPMs noted that when I am on call, that means that's a birthday I don't get to attend, that's a family member I don't get to support, that's a child that does not get my full attention. And I may also have to pay for childcare if I have to run to the hospital to support my client. Also looking at some more Medicaid enrollment supports in terms of tutorials and technical assistance, as well as billing support to create an infrastructure that allows the process for Medicaid enrollment and billing to be less cumbersome. In addition to that, looking at integration and distinction within healthcare and hospital settings. And, we might have to take a look at overhauling some areas of medical settings so that we can expand what respect for community-based care looks like that is provided by birth workers. And what does the bridge look like from community-based birthing to birthing in a hospital? And how do we make sure that that is patient-centered so that that linkage of care is smooth, comprehensive, and also allows that person to be respected? Also looking at better compensation, payments should consider personal costs and in terms of having to provide additional resources or maintain equipment. Also looking at professional development and workforce growth. There need to be more accessible trainings online and in person. That we might need to take a look at a professional development hub where there can be more mentorship. Also, growing a community-based birth worker workforce is essential for our state if we're going to solve this problem. And birth workers themselves need collegial support with one another because this is a stressful job, a very labor-intensive job. And so they need social, emotional support groups, childcare support, and a client resource hubs that helps them to do their work as comprehensively as possible. So I know that was a lot. That concludes my presentation on the Illinois CPM doula workforce environmental scan, labor force analysis, and I'm happy to turn it back over to Anna and take questions at the end. Thank you.
Thank you so much, Camille. That was wonderful, very informative, very comprehensive. There are a couple of questions in the chat, in the Q&A section. I think that you should be able to see those that I think can get a quick typed answer from you about your methodology. So if you want to field those while Karie's presenting, we can focus on the more conversational ones when we get to the Q&A. All right, Karie, you're up.
Thank you so much, Dr. Williamson. On point as always. I appreciate you sliding me into this spot with all the information you gave us. Can you all see my screen there still, or I need to share? Okay, hold on, let me see. Is that better? Okay, perfect. So as Dr. Williamson stated, lots of data about doulas and community birth workers and CPMs experiences in providing this type of care in the settings that they are desiring and the community is desiring. Unfortunately, there are barriers and things, lots of work that needs to be done. And I'm grateful for her work in laying out the landscape of what the numbers look like, what the experiences have been. And so what I have done is to really look at how we can expand and strengthen community birth in Illinois. And so that entailed me doing a little bit more qualitative research with some of the community birth workers and getting their voice out about what their experiences are. And so I would like to share that all with you today. So with that, the question is, why does this matter? Illinois faces a significant maternal health inequity and access to gap, and access and gaps of care. And so, as Dr. Williamson said, yes, we have maternal mortality rates that have not gotten any better in Illinois. Our reports showing lots of access issues, closures of hospitals and clinics throughout the state. Very impactful here recently since COVID over the past 5-6 years. And so we have really seen a loss in care and access for our patients, and community birth can be a solution to this. And so we wanted to really get individuals' experiences on what their clients have experienced, but also what they're experiencing. And so in Illinois, 43.1% of the counties are considered maternity care deserts, with hospital closures limiting that access. And that's throughout the state. Okay. And we know community birth improves access, improves experiences, the outcomes for low risk pregnancies. Also, it allows for collaboration in that we can transfer patients who risk out of that low risk care to those facilities, but we can't do that if we don't have those facilities, or if we don't have access to those providers in those communities. Unfortunately, communities of color and rural families are disproportionately impacted. And so, as Dr. Williamson showed, how many individuals identify as Black, white, and in our Latinx, and as well as our LGBTQ community across the board. You don't see very many melanated or providers of color that are doing this work. And so we really want to focus on how we strengthen that as well. So just a gist of what this concept is, a lot of people are always asking, what is community birth? How do we define that? And it tends to be midwifery-led in a freestanding birth center or in the home, and individuals are seeking to have birth in their home. It is relationship-based, heavily relationshiply based, culturally responsive, and community rooted, culturally rooted as well. And so evidence is shown that shows comparable and better outcomes for low risk births when having community birth, and lower intervention rates, and much more higher satisfaction. And so if we know that communities are desiring this type of care, and individuals are willing to provide this type of care, how can we strengthen this workforce and this option for our communities? And so what I wanted to do was really understand, what providers, midwives, doulas, CPMs are experiencing, and it's just midwives also in the birth center, administrative, staff, just really get their input. And that's who we had interviewed here for our participants. So they weren't just midwives and doulas and physicians, but also other healthcare leaders, birth center staff. And so I wanted to really get a gist of what they thought about community birth, what their experiences with community birth, and how we can translate that to the community. We incorporated some literature review of various birth centers, home birth, midwives, other communities that are doing this work what that looks like compared to what we're doing here in Illinois. And those focus groups and interviews were conducted between April and July of 2025. And we roughly had about 35 individuals that responded to our request to have a conversation about their experience. And so we really, from those conversations and focus groups, got some focus areas that really, across the board, with all the individuals that we talked to, were pretty consistent, and that being access to care, reimbursement, concerns with the workforce, also desires for collaboration and lack thereof, as well as sustainability. And so just some of the key findings that we pulled out of the conversations were also that, access varies by zip code, which Dr. Williamson shared with her heat maps, in that you notice that in some areas it's very saturated, in other parts of the states it is not. And this is the same for providing community birth and midwifery care throughout the state, specifically home birth and birth center care. We have 5 birth centers currently operating, 2 more expected in the new year here. Rural families are hit as hard as some of our vulnerable urban communities in that they travel long distances. And it can be anywhere from 45 minutes to a couple of hours to get care from their community health clinic or hospital. And transportation can be a barrier as well. And so with the hospital closures and the clinic closures, this has worsened inequities in access. And so we want to make sure that we provide a true landscape of what's happening, but also provide some solutions on how to fill those gaps for those closures that the communities have experienced. And so I really wanted to make sure we highlighted the voices from the field. And so in regards to access and equity, some of the quotes that came out of the conversations that we had were access, should not depend on your bank account and where you live. And midwifery care saves lives, but only if people can reach it. And that has been a hot topic in that midwives are restricted from the type of care that they can give, who they can practice with, who they can provide it to based on individuals' ability to pay. In addition to, insurance reimbursement issues, which we'll talk about here in a few, and that has been a barrier as well. Another quote stated, I drive more than an hour just to get to, my client's house because there are simply no other providers around. And so this is hard work for midwives as well. And so we want to make sure that our community has access to a provider, and we tend to be that provider that can fill that gap. But it's also, very strainful on us and our families and missing, family events and life things. And so, we often are juggling, those things and trying to make sure that we're providing care, but also taking care of ourselves. And that can be very hard. Many families don't have reliable transportation, which is, another concern of the midwives and the birth workers in the community. And so if we don't go to them, they simply don't have care. And no one wants to be without care. We also don't want to watch individuals kind of go through these experiences that they're having and not have care. And that's very difficult for us to do as well. In regards to some of the quotes that touched on reimbursement and sustainability, some of those were also shared with us in that if home or birth center labor requires a hospital transfer, the hospital bills for the birth. And so that midwife does not get paid for the time they provided prior to that transfer. And so what was shared was that midwives, and this has been an experience of doulas as well, but specifically in this case, midwives will labor with their patients, care for their patients, do all the things to make sure that the labor is progressing. And if the client desires to go to the hospital or the situation warrants a transfer to the hospital, then that care is taken over by the hospital, but there's no compensation provided for that individual. And they could have spent hours or days with that patient. And so there is that topic of how do we address that? How do we make sure that the midwives get compensated for the time that they've spent, but then the hospital also gets, compensated for what they have taken over and provided to the client on the back end. Midwife reimbursement has to pay for our assistance, our supplies, our licensure, and continuing education, all from one blanket amount. As Dr. Williamson shared, same thing that individuals shared with her, they shared with me about this work just is not paying enough to compensate all of the things that go into this work. And so when you have to pay, for someone to assist you, if you want to make sure someone covers you, if you decide to take some time off, you want to make sure you properly compensate them for that. But you also need supplies and licensure, your vehicle to get to individuals. The compensation that is asked is not enough. And so the question is, how do we make sure we strengthen that? We ask for a very livable wage for this work. We also want to serve Black and Brown families, as one midwife stated, but without reimbursement, we can't sustain serving Medicaid communities. And a lot of the communities, probably in the northern parts of the state, experience a lot of individuals that tend to be Black and Brown on the Medicaid. But in Southern Illinois or in the regional central areas, there are a lot of individuals who are not Black and Brown, but majority of the state of those individuals aren't on Medicaid. That is a heavy population. And so when we don't have a sustainable system for Medicaid and the reimbursement, individuals tend to, utilize just a payment system, paying out of pocket. And a lot of individuals can't afford that, but they want that experience. And we want Medicaid to consider paying for those services at an appropriate rate. As far as the workforce pipeline, there was conversations around this as well. And some of the quotes that came out of there is just not much formal training in stewarding the next generation. There's no structural preceptor system like those that have been researched and seen internationally. And so, the participants in this study really wanted to make sure that we talk about formal training and transitioning into the spaces of community birth, what that truly looks like, what the appropriate support looks like, so that individuals are not burning out sooner than later. And students are more than just students. They are also assistants that have graciously helped midwives in the community, but they're not getting compensated for this work, and it's labor intensive. And so what can we do to make sure that our students aren't getting burned out before they even take on a job, properly compensated for their time, because they also have expenditures that need to be considered when they're learning to get into this space of work. The state has communities crying out for better outcomes, and midwives are ready to answer, but the system has to let us do our work. And, we have many individuals that have worked together in this community and have community-based solutions that we are working on. But we also need the healthcare system, the individuals in these spaces to really join in with us and allowing us to do this work, because we have our feet on the ground and know what works for these communities. And we want to make sure that we're working in partnership and making sure we have access to the resources and the needs so that our community can have better outcomes. And so really making sure that there's an understanding of how the state operates, but also we know how the state operates. They don't know how us as midwives in the community operate. And so really having those conversations, knowing what our needs are, and actually acting on them, and providing what we need so we can do this work. In addition to that, the topic of safety and burnout was a huge concern in the conversations that we had. Again, this work is emotional. We said, before, it's hard work, but families need intensive relationship-based care, and we want to give that. We don't get paid time off, insurance, retirement. We absorb those costs personally. And even if an individual seeks to make sure that they take care of their own insurance, their own retirement, and those personal costs, the compensation still is not enough, as we shared a couple times throughout this project. Solo on-call work without support leads to burnout and threatens workforce retention. Lots of midwives in the community have a solo practice, unfortunately. Individuals want to work with each other. They want to have solutions on how to collaborate with other midwives and other physicians in the community so that this is a collaborative effort. No one's threatened by the fact that someone wants to have a home birth or a birth center birth, but then knowing that if the individual needs to be transferred to the higher level care, there isn't backlash and individuals having horrible experiences when they get ready to transfer their patients and clients to that care. And so we want to make sure that that is an issue that we're addressing in regards to midwifery safety, but also client safety, but also making sure that our community midwives have resources and solutions so they're not burning out and can continue on in this work. Finally, there was also the topic of transfers and collaboration. Many individuals, midwives, have voiced their concerns about transfers. Their experiences have not been the best, even with working with EMS and them, taking over and not allowing the primary provider to do their job and safely transfer patients to the higher level care. And so individuals have stated that they have had good experiences transferred, but not everybody has that same experience. Every community is different. They know about the community birth midwives. Some of them do not. Some of them care for them. Some of them do not care for them. And those transactions that they have are telling of how they respect the community or don't respect the community. And so we really want to make sure that we are educating all the individuals in the community about home birth, birth center care, hospital care, choices to decide which one you desire. But knowing that if you decide to choose one, we also have a solution if we need to upscale you to a different care. And those conversations are not had. I think individuals are thinking we need to pit against each other, and there's this competition. Everybody can have what they want if we have a real hard conversation about what that care looks like and who fits into that type of care. And knowing that respectfully, if I can't care for a low-risk individual, I have a colleague that's willing to take you on and knows that we have had these conversations and you will be safe in their hands and their care in this entity. And so we really want to foster those type of relationships, and that type of stuff is not happening. Some other quotes were, we all want the same thing, a healthy parent, a healthy baby, but the only happens when the system honors our expertise. We are experts in what we know. We are experts in what we know, and we know that individuals who are experts in what they know, we want to be respectful of that, but we also want to collaborate, and knowing that not everyone is going to get our care, not everyone needs the other care, but when we work together, we will definitely have better outcomes. And so these transfer processes are inconsistent across the board, and we want to make sure we make those better. So from those conversations, again, we pulled these categories that I have already shared with you about the access and equity. And so what do we do? How do we address, some of these solutions, creating some of these solutions for these areas? And so we want to fund more birth centers across our state. And a lot of people say, oh, we want to open. It's not just open. We can open the doors. We want to make sure that they're funded and sustainable. And so we have committees and meetings and plannings that have been talking about sustainability and getting birth centers open. We want to make sure that those birth centers, as well as home birth midwives, are getting compensated appropriately so they can sustain their practice. We want to make sure we also have access to midwives within the hospital. And so there's nothing more beautiful than being able to transfer, and I'm speaking from experience, and I'm sure others can share, when a home birth midwife can transfer their patient to a midwife in the hospital. And if we can have more of those connections and collaborations, and the hospitals consider having midwives on their team, that will allow for a better experience and successful outcomes and transfer as well. We want to make sure we also have adequately staffed and reimbursed the safety net hospitals that we're going to. Those entities need support as well as we utilize them, and they continue their services as well. And so this is just some of the quotes that were pulled from that to help us create some of these resolutions for these categories. That being, fair reimbursement. We want to set Medicaid rates for, all midwives, nurse midwives, CPMs that are equivalent to the hospital providers. We're doing this work. We should be compensated the same. We want to include those facility fees for birth centers and all-inclusive home birth fees. We have to create that and tell you what that is. We can do that, not a problem. But those things need to be compensated for as well. And so we want to pay for labor prior to the hospital transfer that I touched on, to remove those safety disincentives. And so streamlining Medicaid enrollment, billing infrastructure that really needs to be much more solid so that we can utilize those entities, and those individuals that seek to have home birth and birth center care can still get that care no matter if they have Medicaid or not. We also want to make sure that we're funding our students appropriately with scholarships and stipends. And, teaching students is a lot of work. We're working and teaching. That's a lot. And so we want to make sure our preceptors are reimbursed appropriately, that they have compensation enough to support their students and also their assistants. And so this is a workforce. We have to make sure that we're strengthening it and providing an investment in it like we do everything else. We want to support the structured preceptor training and mentorship, whatever that looks like, however we deem is necessary for that community. And we need early exposure. We have to go into the schools earlier and, let students know that this work is something that is very rewarding, but also can be done, and that this is who we are and what it looks like. We are in the community, we provide these services, and you too can consider this as a profession as well. But we absolutely want to make sure that we are expanding OB/GYN workforce in the underserved areas, midwifery care, birth centers, home birth, doulas, all of those things across the board should be offered to our underserved communities. And then for our collaboration and transfer, the suggestions of standardized statewide hospital transfer protocols. There are a couple of states across the nation that have these. Illinois should be next on the line to start to adopt a statewide hospital transfer protocol that works for us. And our safety net hospitals, especially in our rural communities that are being hit very hard with lack of access, and that will need support and transfer care. And we want to require our hospitals to accept those transfers from the birth centers and home birth with a smile. We want to designate the hospital liaisons and share records. I think this is all too often, we hear midwives say that I've called, want to give a courtesy call, tell them what we've done before the client gets there, and really, so the client isn't repeating themselves and having these traumatic experiences. And some of the individuals haven't been very receptive. I know physicians have concerns about quote unquote getting train wrecks and, having to do surgeries or, not having a responsive baby when mom gets there. And, all of this stuff can be alleviated if we just talk, have conversations about who's in your community doing this work. And it doesn't have to be at this junction of when someone needs care. Meet the midwives in your community, know what they're doing, who they're servicing, how can you support them? Let's go to the hospital and make sure that they know that we're there and have those conversations and not, try to pit each other against each other. Community is community. You're in the community, I'm in the community. We want to support each other. How can we make sure that our community is served appropriately? And so those conversations really need to be had. And we need to have them sooner than later because we have more people dying than we would like to see. And those things are preventable, as our state report says. And so let's establish some referral agreements and some collaborations with some imaging centers and labs so that everybody's on the same page about where individuals are going and where they're getting their care and sharing that information so that it allows us to provide the appropriate care. We also want to make sure that our midwives are safe and that we have sustainable practices. We want to promote this team-based care that I just spoke on. And we absolutely have to incorporate some mental health and peer support, how we get case management enrolled in that. I know we have some home visiting programs, but we really need to tighten that up and have those individuals at the table with our communities, not on a larger scale, but in our smaller communities. What resources are available? What are you doing? A lot of people don't know what they have access to, who they can support, who they can refer individuals to. And so if we don't know you're there, we can't refer you to them. And we want to make sure we ensure those people have adequate staffing and compensation and benefits. And so, we have lots of work to do, but it absolutely can be done. And so my call to action for us in the state of Illinois is to really partner and expand access to safe, culturally responsive birth options and all the options: home birth, birth center, hospital, provide midwives in all those spaces. Make sure we have culturally responsive care in those spaces. Make sure all cultures, ethnicities, identities are represented in those spaces as well. No one's going to utilize that space if they don't feel safe, they don't feel that they're going to be heard, and they don't see individuals like themselves. We want to invest in sustainable community birth infrastructure, and we want to commit to equity-driven policy and payment reform. It will make for an easier workforce, transition for individuals, continuation, and strengthening of the structure. But more importantly, we need to center the community voices in this implementation. And that's all I have.
Thank you so much, Karie, and a huge round of applause and thank you to both of our presenters, Karie and Dr. Williamson. We are so grateful for now having this data that demonstrates the urgency of the moment and the amount of work that is need to be done in order to make sure that these resources are inclusive, are accessible, and are equitable across the state. Got a lot of great questions for you in the chat. I'm gonna lump some of them together for efficiency. There's a number of questions around who was included in the sample sizes and the representation around Chicago versus downstate and the imbalance between that recruitment. So I'm wondering if both of you can speak to the relevance, some of the challenges with recruiting folks from downstate and the relevance of the findings and the relevance of applying the findings that you have to downstate environments, given that they were underrepresented in your samples.
Yeah, I'll start with the midwifery workforce. I had probably more one-on-one individual conversations with downstate midwives, but experiencing the same issues as further up in northern central Illinois, that there's a lack of care, there's a lack of resources, transfer agreements issues, collaborations are an issue as well. But majority of them were certified professional midwives, some certified nurse midwives who are doing community birth work, home birth, birth center work. Spoke to various individuals in the birth center as well, and gathered their experience. But again, what you have to know is people are busy. It's hard to get people to stop and talk to me about their work when they're working. And if you don't have a lot of time and a lot of energy, it's hard to get that information from them. So when I got it, I was grateful for that. But across the board, it's very similar. Lots of hospitals and clinics have closed in Southern and Central Illinois as well. And so the issue is there's no public transportation like you have in the urban areas. And so that is very hard for individuals to get around to hospitals, clinics in their area. And so if individuals deem that I may not go this visit, but I'll go on another visit another time, you're kind of deciding when is a good time to go for care, and that should never be done. And then you have midwives sacrificing themselves to go out and see these individuals and make sure that they're okay. And that's not a good solution as well. They will eventually burn themselves out, and they don't have additional help. So across the state, similar, even though we didn't have so much concentration of individuals coming out to speak in the Southern and Central area, those who spoke are in the spaces and experience the same things that are happening in the northern part of the state as well.
Thanks so much, Karie. I can add to that. So there isn't necessarily like some big old database of every type of doula group or every person that is a doula or a CPM in the state of Illinois, which presents the challenge itself to make sure that we have this full representation. I believe I responded to one of these questions, and Anna can attest to this. I wanted a much larger sample size, but we had to start somewhere. And that's not unusual in research, especially when you're trying to get closer to solving a problem. It's not unusual to have to repeat certain surveys as well as you start to gain more reach and more access to people who are trying to solve the same problem that you are. So to answer that, I would say this is a essential start, and data collection is typically ongoing to make sure that, number one, you are incorporating the perspectives, the information from people who are working on this issue or affected by this issue, and then evaluating whatever solution is being brought forward to see if what is the impact? Is the solution doing what we needed to do, or do we need to go back to the drawing board? Did we miss something?
Thank you both. There's a number of questions from Mary Summers in the chat. Thank you, Mary, for all of your thoughtful questions here. I wish that I could take you off mute and have you ask them out loud. But a lot of them are around the assumptions that were made around calculating the real cost of doing this work, and how you are calculating what it should be, what the reimbursement rates should be, the consequences and unintended impacts of raising those rates. And so I think that's a much longer conversation. And Mary, I think we're going to follow up with you outside of this time to have a deeper conversation around your recommendations for that as we're building out advocacy materials. But my question for the two of you is, what, aside from just increasing, the rate of what a postpartum visit reimbursement looks like, this still doesn't address the fact that a lot of these workers don't have health insurance, they don't have retirement benefits, they don't have all of the resources that salaried professionals have. So what recommendations would you have for making sure that this workforce is not just having higher Medicaid reimbursement rates, but is actually being cared for in a sustainable way when it comes to their employment contracts?
So I really like this question, and I think it opens us up for a larger discussion around really honoring what labor looks like, this type of labor. So just sort of smushing in this in the conversation around integration. So if Illinois is looking at integrating more doulas and CPMs within, formal healthcare and hospital settings, and also looking to expand community birthing options like birth centers, what is the standard salary that this type of labor demands? And I think you have a number of different perspectives. Like, I've heard some CPMs say, well, I should get paid what an OBGYN gets paid. We're doing the same thing. And I've heard some OBGYN say, absolutely not. We don't have the same level of training. So I think these are, I think both myself and Karie kind of alluded to this in our presentations about all of these different layers in terms of what integration would look like. And there are going to have to be some hard conversations about what is fair pay for people, because everybody is going to say, well, my training was this extensive and it was this intensive and I paid this much and I had to do this and it took me this many years, blah, 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 so on and so forth. So I should get this. And so I'm wondering if there's some questions we're not asking. If you are a healthcare worker, because I especially appreciate Karie highlighting that this work needs to be safe for the people who are doing the work. And to me, safety isn't just about physical safety, it's about protecting that worker's health. So what are some more radical questions we could ask about people who do any kind of work within healthcare settings, community health workers, doulas, CPMs? What is the standard of healthcare that they all need? And how do we ensure that they're getting it? And what does that look like in terms of a state-based model to ensure that we're taking a fair, comprehensive, and safe approach, just to use Karie's word again, in terms of establishing a sustainable workforce? Because one of the things that I think echoed in both of our presentations was this level of burnout. So if you've got doulas and CPMs, both managing a caseload on a monthly basis, as well as an additional job, as well as whatever familial responsibilities they have, I could definitely understand why the burnout persists. But people keep going because they really care about the work. So how do we care about the people who are doing the work? What are the radical questions that need to be asked in terms of if we're trying to establish a standard of care for birthing people, what is the standard of care that is necessary for the workforce that takes care of birthing people? So I'm sorry to answer with several questions. You know how my brain
works. There's a lot of
I'm
information that's not had in order for us to come up with that solution. That's really what it is, and we want to be fair across the board for everyone. But what we have to define those things in order for us to come up with those solutions. So, in all fairness, as Dr. Williamson saying, we need to have more conversations, and I'm glad we're starting this because we need to have several individuals at the table in order for us to create what that looks like. If we're creating an entity that allows for retirement for the workforce that's doing this work, we want to make sure we create that, but we need to know what is needed and what is the definition of some of the things that's going to be involved in that.
And I'll just put a plug that if you are interested in these types of conversations, we want to stay in touch with you, because we are going to be working on proposing alternatives and exploring what other models will work better so that we can make this system sustainable and thrivable, both for birth workers and for the clients that they're serving. Karie, there are a couple of questions in here about birth centers, where they can be tied to an FQHC? Are there restrictions on how many we can have in a particular area? Why are they some places and not others? Can you just talk a little bit about how birth centers are, who they're affiliated with, how they start up?
Yeah, so you have birth centers that can be, freestanding, that the individuals can have that are attached to a hospital or, FQHC run or affiliated. But then you also have individuals that have just had their own, birth center and funding to do so to get that going. Every state is different. Illinois, we have expanded those requirements. I would encourage you to seek out the birth center task force because they have done a ton of work on this policies. And if somebody wants to drop the website in the chat because they have lots more thorough information on that. But myself and Janine and the health and medicine group, back in the day, it's been a while now that we, help with those policies to increase the number of birth centers that can be in Illinois. But it's about funding, and having access and money to do that. Having hospitals on board, making sure you get it in the, as travel space, as sort of say, in that you want to make sure you're at least 20 to 30 minutes away from the hospital if there needs to be a transfer there. And so there's very strategic information that needs to be had before you consider that. And the Illinois Review Board, Hospital Facilities Boards, is integral in that process as well. But more conversations can be definitely directed to the birth center task force in specifics, but we can have more. We definitely can have more. State of Illinois wants us to have more, but we need more funding. We need it to be sustainable. We don't want to build them up and then they, aren't there for, only there for a year or two. We want to make sure that midwives are compensated appropriately. Birth centers need to be able to pay the midwives and their staffing. And so therefore reimbursement needs to be appropriate and facility fees need to be taken care of. And so it's a lot of things that go into that, that you have to look into before you just kind of put up a birth center.
Yeah. And this, it takes a lot of work. The Southside Birth Center has been in process of becoming an active birth center for over 5 years. So this is not just, a snap our fingers and make a new birth center. And Gail's dropped some links in the chat to get connected with the Birth Center Task Force and to learn more about our work with birth centers. You can email them or click on those links. My last question is just a final thought question for the two of you, which is, if there's one overwhelming recommendation or finding that you really want to make sure that this group leaves with today, what do you think that would be?
Collaborative care. I mean, we cannot not do this and solve the crisis that we're having, whether it be access, whether it be deaths, whether it be the workforce, whether it be, sustainability. It has to be collaborative, period. And no one should feel threatened by the other entity because they feel like they're getting more money or they're getting more recognition, or they do this over that. Everybody has a place in this solution. And once we recognize that place and respect each other's ability to do what they do, we can all work together and solve the problem. And Illinois could be such a beacon of the example of how to do this in our entire state, because we have lots of resources, and we also have legislation and individuals that are willing to invest in this. And so we really need to take the opportunity to do that and work together, and individuals learn what midwifery care is and how we work, and do what doulas do and what case management does, and all those roles, for we can really do some collaborative work to collaboratively solve this problem, but also have great experiences in birth that we are all entitled to experience.
I agree with that. I would say put the community back into the birthing experience and being able to understand that a person that is giving birth is an integral part of a community, and is bringing somebody into the community that must be cared for. And the reason that resonates with me in tandem with collaborative care, as Karie said, is that in order for us to solve this problem of maternal mortality, maternal morbidity, along with what a lot of vulnerable and marginalized populations experience, we have to have a human rights focus. We have to understand that everyone here is moving towards the same goal of improving maternal child health outcomes. So when I think about improving maternal child health outcomes, that means what are the resources for people who are struggling with addiction and how do they get connected? What are the resources for people who are immigrants and dealing with this current political climate? What are the resources for people who have insecure housing or are unhoused? All of those things are in concert or at play. Like, yes, we want to make sure that birthing people don't die when they're giving birth and that children thrive, but into what? In how are we going to make sure that communities are healthy and safe for people who are birthing and for the people that they have birthed? And so in that collaboration, what is our resource development and what are the kinds of conversations that we need to have to put the community back into this conversation so that we're not just thinking about numbers or percentages, but more about a human experience that is indicative of a health equity perspective that allows for everyone to thrive.
Very well said, Dr. Williamson. Thank you so much. And thank you to both of you again for sharing, for your research, for sharing and speaking on it today, and for the work that you both will undoubtedly continue to do to advance maternal health equity in Illinois. I'm just going to wrap us up today and remind folks that this is just the first in a series of webinars preparing for the launch of the community-based birth justice strategic plan in Illinois. We've got 3 more left. They are every Friday in February for the rest of the month. Next week is, for those of you who had questions about what else is happening in other parts of the state, next week will be a focus on both downstate Illinois, Southern Illinois, as well as taking a broader look at not just doulas and midwives, but community health workers, substance use workers, folks that are touching what Camille was just talking about, the whole spectrum of folks that impact perinatal care. Session 3 is going to focus on racism, discrimination, and their impact on Black birthing people. We know how much of an impact this has on birthing people's health outcomes. And so we must address it. We must understand it so that we can figure out how to devise solutions that speak to those challenges. And the final session, the last Friday in February, we will bring together all of our panelists to talk about how the overarching themes inform the strategic plan. And then we will, of course, walk through the strategic plan in its entirety for all of you who are interested. And we'll talk about ways to get involved in that process. So you can register with that QR code there. Leandra, please drop the registration link in the chat as well. Big thank you to everybody who helped make this happen, our researchers, the coordinating committee who guided this work, other community-based birth workers who helped generate the contents of the plan, everybody who participated as subjects in this research, and our generous funders. You can find a full list of all these participants on our brand new website that is live as of this morning, birthjusticeillinois.org. Leandra, please drop that in the chat as well. Or go to our QR code right here, birthjusticeillinois.org. At the bottom of every page or at the QR code on the right is an interest form if you want to sign up and either, get regular updates on what we're working on, sign up to help advance one of the goals in the strategic plan, or do something else. We would love to get connected. We would love to welcome you into our community and work together to advance birth justice in Illinois.